Now this was a shameless promotion here by myself. 1995, it says, this was actually when we first did our cryosurgery using the three-dimensional techniques instead of just the two-dimensional techniques. It says local procedure promises hope. I hope you can see that. I just want to put it here. This was on, I think it was a Saturday morning paper, local paper here. So I showed this picture one day in one of the meetings like this, and then someone put up his hand and said, "That probe looks really big." Which is right there. Right there. Kind of like this here, except that, I guess, I always remember that story. Anyway, so here's the I think I'm okay here, yeah. So this is sort of a three-dimensional view of a real-time. You can see it on two views, but down here, look here. Now, that little spot is where we want to target, but then we also want to make sure once you fix that over there, you want to make sure that it goes there as well to coordinate it before you fire. So, and that's where you want to target a location. So that's the three-dimensional kind of just a 3-second explanation of how this coordination with three-dimensional ultrasound works instead of just having a two-dimensional view. This is one way of doing this. So how has cryosurgery done then? As so-called primary treatment, in the States it's approved, but in Canada it really hasn't been used as a standard treatment. As you know, there's radiation, there's surgery, there's hormone treatments. Freezing has been really kind of out there. Not too many people have been doing so-called primary freezing procedures. Calgary, one of my colleagues, Brian Donnelly, has been doing some, and I've been doing some, but I've been doing mainly for people who have failed radiation, as I said, as part of a randomized study and for different, only for a select group. The thing is, why it hasn't caught on a lot is because there are still problems. In the 1990s, even with all the improvements that I showed you, there are still a lot of problems in terms of the publications, people publishing the results. Of course, you publish the results if your results are good. If they're not so good, you don't bother publishing them. So what you see on paper, what you see in the journals or in the news are the better results. Very few people will say that, well, this really didn't work at all. And so in essence, there's selection bias, there's publication bias, and so forth. And a lot of the studies that came out or that were published in the journals had pretty short follow-ups. So that was some of the problems. And a lot of the publications said, oh, there's actually no side effects. Well, like most things, if it sounds too good to be true, it probably wasn't. Now, so if you were doing so-called primary cryosurgery, urinary leakage problems, it's not too bad. It's less than 1%. But remember I showed you where the urethra, and it could slough and could block the urethra, and it's still close to the rectum. It's about 1 out of 100. But most people did become impotent because the nerves, as most of you know, the nerves that control erections are very close, in fact, to the prostate. And you freeze the prostate, the whole thing becomes one giant icicle or popsicle. Then the ice actually will be touching the nerves, so they do get affected. So rectal injury, just to explain it better, here's the rectum again, here's the bladder and the prostate there. If it's so close, if the freezing wasn't controlled properly, it will freeze too far and can damage the rectum, and it goes right through here and causes what we call a fistula. And the fistula, what it is basically like a communication between one side or another. Like if there's an old crumbly wall and there's a hole in the wall here, so whatever's over here can seep over to the next room, whatever's over there can seep this way. So that would be a problem if you have, rectum, which is where bowel movements come down here. If there's a little crack, some of that can track towards the bladder or urine side, and whatever is coming down through the urine, which is obviously urine, through the urethra, through the prostate, can track the other way. So that's a serious problem. So that's something that's, it's not that bad if it's so-called primary cryosurgery, first time doing it, but it's still something that we really are very much aware of and try to avoid. As I mentioned, it should be less than 1%. So there's the fistula, the little picture I showed you. So there have been a lot of results that have built up over the years now. In 2000, several thousand patients. There's a so-called COLD registry. Again, it's memory cryosurgery. The problem with some of these, just to tell you, is that the data collection from many of these for the publications came from non-medical personnel in the office that they just put data entry, and the other thing is the voluntary reporting. Like patients will report side effects, but if they don't report, then it's not captured. And there's no verification of some of these results either. So I'm not criticizing these particular publications, because these are very credible individuals who do good quality work. But the fact is they are limited by some of the data they've collected over the from various places around North America. So just my message really is that it's still some of the publications still have some limitations in terms of the actual results. Now, I mentioned in terms of in Canada, there are two trials that went on. One was by my colleague Brian Donnelly in Calgary, who compared external beam radiation versus cryosurgery. Now, this is what we call a randomized trial. Some of you have been involved in trials, I'm sure, that are familiar with it, with this whole concept of randomization. And this is really one way, a much more foolproof way of comparing a newer technology compared to an older or standard way. So the idea is that people are so-called randomized into one or the other, and they have, just say if you have 250 people here, half will be randomly assigned to this, half will be randomly assigned to the other. The physician and the patient are not really the ones who make the decision as to which way they go, which the idea is to safeguard against any decision bias, so that you don't stack the cards one way or the other in terms of having favoring one group versus the other. And these are the results from Brian Donnelly that showed cryosurgery actually had better results in terms of doing a biopsy 3 years later, lower percentage of biopsy results than people who had external radiation. Now, this is for low-stage cancer, so lower risk prostate cancer, small volume prostate cancer, early prostate cancer that have not been treated. Now, this is for high risk, higher stage cancer. This is actually, we did that, our group did that. For more advanced cancer, again, these patients have not had any other treatments, and they were randomized into cryosurgery or radiation. They had a bit of hormone ahead of time, and then a few months of hormones afterwards. So same idea, again, these were randomized. So again, it actually produces so-called higher quality evidence that you can rely on because it's randomized, rather than just a whole series of people just getting one treatment without a comparison group and so forth. So in our results, actually, for the higher risk patients, actually showed radiation was a bit better. So that's the opposite for the low risk that Dr. Donnelly showed, and with cryosurgery for the lower risk patients. Okay, so these results for high risk, more advanced, bulky, so more bulk, cryosurgery by itself didn't work well. So that was the conclusion for that for cryosurgery. Now, for the United States, the FDA, the Food and Drug Administration, they came out about this time with the overall statement, so-called best practice statement on cryosurgery. The overall conclusion was that there was no level 1 evidence. Level 1 evidence means that that's from randomized so-called prospective trials. As I say, that's rid of any perceivable biases, but there are no trials to support the role of cryosurgery over other therapies. They did quote the papers from Dr. Donnelly and our paper, but basically that's only 2 in the whole world. Okay? In the United States, there were none. There were no randomized studies because everybody just either thought it was the greatest thing and jumped on the bandwagon, or they thought it was no good, and so no one actually took the time or to actually do this randomized studies. Anyway, it did say that 7 or 8 year results of cryosurgery they had those results. They said that the morbidity profile, meaning the side effects and so forth, has improved over the years, and overall, they actually had approved cryosurgery as a treatment in the United States. So in Canada, it's still not being used very much in primary treatment. Now let's move quickly to salvage therapy, and that's after radiation. Now this I find, again, same technology that I mentioned, this I find to be much more justified, really, and that's why we started in the first place. For people who have radiation, if the radiation failed, what other options do we have? Well, you could still go and take the prostate out, so-called salvage prostatectomy after radiation had failed. Now, this is 200 patients from a large series in the United States. The injuring the rectum, 5%, urethra scarring, 22%, severe incontinence, 25%. So, in other words, they're pretty severe complication rates and it's not a great operation for some people. For the younger patients, yes, but it's a pretty morbid type of operation. Major operation, significant complications, as I mentioned, suitable for relatively young patients. On the other hand, cryosurgery would have minimal blood loss, just with the needles, and as I told you, it's a 2-hour, 3-hour procedure, less invasive for that particular group, so that's why it's minimally invasive. It's better tolerated by some people with what we call comorbidities, so you have some heart problems or lung problems, diabetes, whatever. It's still okay. You can tolerate the anesthetics reasonably well. And even if the cancer is a little more advanced, you can still freeze it without, within reason, of course. And so I've been doing this for a lot of years with cryosurgery and follow-up in some patients up to 15 years, and we've published those numerous times in different stages and follow-ups, and I can say that approximately 40% of those people were cured. Now it doesn't sound great, 40%, but when you look at it, these are people who have already gone through the major radiation over the years that have basically exhausted other alternatives, and 40% actually isn't too bad. But the key is for us to choose the right candidates, make sure people who already had disease that have gone past the prostate, unfortunately they're not suitable for this. And then of course I use the three-dimensional ultrasound technologies and other newer technologies with cryosurgery to maximize our efficiency of cryosurgery. So this is different numbers, 168 because it's slightly different follow-up of the same patients. Again, we published these. You can say roughly between half to 2/3 of patients were still okay 10 years later. So that's pretty darn good, I must say. And other people have similar results with, this is again salvaged. So these are patients who, as I say, have had already fewer options open to them. Now, I'll talk very briefly about focal treatment. Remember, I mentioned just targeting certain areas. We could do this with radiation failure as well, so a little target that would just go. This is one of the papers that shows, I don't know if you can see it that well, it's a male lumpectomy, like females with breast cancer. Instead of taking the whole breast, doing mastectomies, they're doing lumpectomies. Same idea, but the prostate though, even in this man here, this prostate here, just an example, this is a big area, but he also has another little area there, another little tiny area. So the thought is maybe we just treat this and maybe watch that, or do this later. That's possible. And that would actually lower the complication rate. And for some people at this stage, maybe it is reasonable to just do what we call palliative, or do it in stages. So it's a bit of a compromise, but it works for some people, and it does make sense. So the male lumpectomy. The challenges of focal therapy, as I was alluding to earlier, is how do we know that that's the only place where the cancer is? You really do need to have a good map of the whole prostate, and that's the challenge. Even with the three-dimensional ultrasounds, with MRI, magnetic resonance imaging, with PET scan, and other things, numerous groups around the world are doing, different studies, fusing the prostates images and so forth. And we're doing them, collaborating with two groups in Toronto, actually, with Princess Margaret, with Sunnybrook. We're doing various things, but we still don't know for sure whether we can target, or should we target just one area, or half the prostate, or this area, or that, or numerous areas. As I said, it's a multifocal process, the cancer is. And the challenge is to do what we call accurate localization. Even if you localize it one time, in the X-ray department, you localize, oh, here it is on the screen. Well, when the patient gets off the table and you book, schedule, say, a procedure, freezing, for example. Well, 2 weeks later, you go in, even just placing the probe back in the right spot, you can't put it exactly the same spot as you did 2 weeks ago. And the patient would have moved a little bit. Very simple, mundane things like having a bowel movement, or when he had a bowel movement, would have changed the pressure on the rectum side onto the prostate. So it's quite a challenge to relocalize, this particular spot. And just remember, what I'm pointing here, say this is two-dimensional. In fact, the whole process is three-dimensional, right? So in fact, it could be right there, but it could be here, or it could be much deeper in. So it's a three-dimensional thing. So the whole idea of this 3D ultrasound and 3D imaging that I mentioned earlier does help to some degree, but it's still a challenge. So several groups, this is from MD Anderson, I won't get into details here, but they actually were freezing 2/3 of the prostate. They call this the hockey stick, but pretty, just to spare part of the prostate. So they call this focal therapy. But basically, to summarize that, focal therapy is emerging, but really not ready for prime time use yet.